Thank you, everyone. Thank you for inviting me. And dear friends and colleagues, thank you very much for extending your stay until my talk, or just seeking for shelter because of the rain outside. My name is Timo Grimmer. I'm head of the Center for Cognitive Disorders at Munich, Germany. And it's my honor to give this presentation on the concordance between Florbetapir PET and the Elecsys beta-42 CSF immunoassay in association with recruitment in the phase 3 anti-amyloid immunization program run by Roche called CREAD and CREAD2, which evaluates the safety and efficacy of crenezumab in early Alzheimer's disease. And as you all know, in case of any of these monoclonal antibodies will be approved in the future, one of the bottlenecks we will focus would be how to get the information on amyloid positivity on all these subjects. And so I think it's still an important topic, even if it's not in plasma. These are my disclosures. Notably, I think I'm the only author who is not a member of the Roche family yet. In observational studies as seen throughout the conference and published just recently, it has been demonstrated good concordance between amyloid PET, here for example with Florbetapir, and the Elecsys beta-42 test with 84% concordance, or with flutamidamol and CSF beta-42 with 80% concordance. So imagine that it would be really challenging to get the information on amyloid positivity to all the future patients who require treatment. I think using PET alone, it will be really challenging to achieve this aim regarding the price, the availability, the exposure to radiation, and hence the assessment of beta-42 in CSF using such kind of highly accurate, fully automated assays might become an alternative. Just a few reminders on crenezumab. That is a humanized anti-amyloid monoclonal antibody. It's an IgG4 antibody, and the low effector function of the IgG4 backbone and the lack of crenezumab binding to vascular amyloid are hypothesized to minimize the risk of inflammation in brain and thereby lower the risk of ARIA-E, which allow high doses to be administered. And crenezumab is designed to neutralize neurotoxic A-beta oligomers and has shown proven target engagement, including just recently at AIC. And this is the trial design of the two identical phase 3 studies using crenezumab in early AD, and early AD is operationalized to meet a global CDR of 0.5 or 1, an MMSE of greater than 21 points, in addition to episodic memory impairment and certainly amyloid positivity. And I think it's notably that the trial, the double-blind portion of the trial runs for around 2 years. Patients are randomized at a 1-to-1 ratio, and crenezumab 60 milligram per kg is administered intravenously every 4 weeks. In addition, open label extension is offered to all patients. Of all those patients who progressed until amyloid testing, which means that they already fulfilled all other inclusion and inclusion criteria, they've been asked during screening, before amyloid testing was done, whether they were willing to participate in the Concordance sub-study. Otherwise, they could have chosen whether to be screened using amyloid PET or CSF, and fortunately 112 participants agreed to participate. Of those, 77% scored positive on, or were read out positive on amyloid PET, and 79 were read out positive using CSF. The platform used to determine CSF Aβ42 and later in addition p-tau and 181 and total tau is the Elecsys platform. All of these markers are CE marked. The machine runs fully automated and allows to have the results in 80 minutes turnaround time. And these are the patient characteristics, the demographics of the Concordance sub-study, and as you can easily pick, they are highly comparable to the whole sample of patients who made it until amyloid testing during screening in the CREAD program, and highly comparable to those who have been randomized in the CREAD program too, which means they have a mean age of 70 years, the majority is female, the mean CDR is CDR SOB is 3.2 points. The majority have been scored with a global CDR of 0.5. Mini-mental was around 25 points. And these are the main results. The concordance between those being amyloid positive using PET and amyloid positive using CSF Aβ was around 85%, and certainly calculated by adding the concordantly positive patients and concordantly negative patients through all participants. And on the right, here are depicted the Aβ42 values in CSF stratified by being positive on PET2 or negative, and as you can easily pick up, they nicely separate here. In addition to this high concordance rate, CSF Aβ42 is also highly predictive with a positive predictive value of 90% for amyloid PET positivity, as calculated by the numbers of correctly judged Aβ42 positive patients through all Aβ42 positive patients. In research, in addition to using Aβ42 alone, several ratios have been proposed to might add additional accuracy on whether a patient is suffering from Alzheimer's disease. So the same ratios have been applied to this concordance sample. Here in the middle is a ratio of the marker for neurodegeneration, total tau, as divided by Aβ42, and here on the right, the ratio of the tau marker, phospho-tau, as divided by Aβ42. And you can see concordance rates are slightly higher using this, consistent with what is published in the literature, and maybe adding slight additional value. To further visualize this, you can see this is the original Aβ42 cutoff applied, and in red those patients who were positive on PET, and blue those who are negative, and applying such kind of ratios would certainly help to include those red dots here on the right upper corners. So in summary, there was an overall of concordance of 85% between Florbetapir PET and CSF Aβ42. In addition, there was a high positive predictive value of approximately 90% for CSF Aβ positivity, and one can conclude that concordance between PET and CSF measures justifies using both methods to enrich for patients with amyloid positivity in a clinical trial setting. I, and certainly Roche, like to thank all the patients, their families, caregivers, the principal investigators and their teams who are participating in this study, and to acknowledge crenezumab was discovered and is being developed in collaboration with AC Immune Switzerland. So thank you very much for your attention, and I'm happy to take questions if any remaining ones are there. Thank you.
We have time for questions. Please.
Hi, is there any evidence for difference in therapeutic effect with discordant individuals?
Difference, it would be a very interesting subgroup analysis as soon as the CREAD program is finalized. Not yet.
Any other questions? We have time for another. I have a question. What are the plans for moving forward?
With regards to this particular trial, fortunately everything is running smoothly. The trial is fully recruited. With regards to the Concordance stuff, certainly it is, I think, for one of the companies developing a β-42 in CSF, it is very favorable results, which allows them to more actively push this kind of assessment as a recruitment tool in clinical trial setting.
Is there a plan for validating, qualifying, submitting, anything specific in terms of, regulatory or acceptance criteria of some kind?
The whole platform, or in particular the CSF A-beta-42 and phospho-tau total tau, are already approved and CE certified. Right. Certainly, Roche aims to further extend this platform to markers. Many of them have been already shown preliminary data here at this conference, and hopefully they stay engaged in this field.
Okay, thank you very much. Thanks for your presentation.